Good evening.
Recording in progress.
Good evening all. I am Lakshman Pati. On behalf of MCure Pharmaceuticals, I welcome all the delegates for this no thrombosis program. To share some of the highlights about the no thrombosis, that I am very proud to announce that this no thrombosis has been awarded as one of the most engaging scientific platform from a pharma company in the year 2021. And this all credit goes to all the delegates and doctors, our course directors who have made this possible. So with that background, the no thrombosis is one platform which gives an opportunity for all the doctors to share their real life challenging cases of clinical cardiology, particularly related to patients with CAD, PAD, DVT, PAF, and COVID-19 coagulopathy. So this platform has been a very, with that background, has kept a lot of participants engaged. They have learned a lot of new things. And because this is a platform which gives an opportunity for a real life case discussion. And now with that, to make this program more interactive, more successful, in fact, Dr. Praful Kerkar sir, who is our post director, he has been instrumental in driving this program. So it's my honor to introduce sir, because sir doesn't require any introduction, but as the tradition calls for. So it's my honor to introduce our post director, Dr. Praful Kerkar sir. Sir is former president of CSI Mumbai chapter. Sir is chairman of Board of Studies, Maharashtra University of Health Sciences. Sir has presented numerous articles and he has been part of many national and international meetings, including prestigious orations and awards. Sir has several publications in national and international journals. Sir has been instrumental in CSI guidance documents on acute MI, HF care during COVID. Sir is chairman of Pinnacle India Registry in collaboration with ACC. Sir has been instrumental and he has been one of the key member for many reputed trials like Paradigm HF, Paradigm MI, Oasis Outcome, Select, Sport, Impact, and so on and so forth. So I thank Dr. Praful Kerkar sir for accepting our invitation and to be part of this program as a course director. Thank you, sir. To make this evening more interactive, we have been joined with by Dr. Sameer V. Pagad sir, who is our moderator for this program. Dr. Sameer Pagad sir is presently working as a consultant interventional cardiologist at Bombay Hospital and Medical Research Center, Mumbai, and Jupiter Hospital, Thane. Sir has more than 18 years of experience in the field of cardiology. Dr. Sameer Pagad sir has spent a considerable amount of time on research and having conducted numerous clinical trials. Sir has participated in many national and international conferences. So let me thank Dr. Pagad sir for coming to this program as a moderator. Thank you very much, sir, and welcome you to this program. Then today we are joined with two speakers. The first speaker for this program is Dr. Rajiv V. Sharma. Dr. Rajiv Sharma has completed MD Medicine and DM Cardiology. He is a cardiology head and consultant interventional cardiologist at Cardinal Gracia Memorial Hospital Trust, Vasai. Sir has many articles published in national and international journals. So Rajiv sir, I welcome you to this program. And the second speaker for today's evening is Dr. Amay S. Chavan sir. Dr. Amay Chavan sir has completed MD Medicine and DM Cardiology. Dr. Amay Chavan is consultant interventional cardiologist and presently working in Ananta Care Medical, Mumbai. Sir has expertise in central venous line insertion, arterial line insertion, and coronary angiography. Dr. Amay sir has participated in many CMEs, webinars, and conferences as a faculty. So I welcome Dr. Amay sir for this program. Without taking much of the time, I would request Dr. Kerkar sir to take the proceedings forward. Over to you, Kerkar sir.
Well, thank you, Dr. Lakshman, for those kind introductions. It's a good evening, firstly, to all the delegates who are assembled today, as also my co-faculties here all of them from Mumbai, very dynamic young people, right? Samir has also been associated with me at KEM for a long time as a student, good old days. And then we have Rajiv Sharma and Amay Chavan, also Mumbaikers, both of them. And also, I'm sorry, I don't recollect Amay as being from KEM, but he is definitely from Mumbai again. Yeah. So having said that, I think Amay Chavan will, I'm sorry, Rajiv Sharma will join later, I'm told. Yeah, right. So we'll begin with the first speaker as being Amay Chavan. But before we begin, to set the context out here, as all winning we course directors as well as all the moderators and speakers deserve the credit, in addition to the delegates, that it has got the excellence award, this no thrombosis thing. Thanks to COVID, we got associated with this program, and that's how the name got coined as no thrombosis, with no highlighted in the middle. In an ideal world, we would all like to eliminate thrombosis, right? Because everything that we deal with as cardiologists or as physicians has got to do a lot of morbidity as well as mortality associated with thrombosis wherever it is. And we all know today that NOACs have gotten established as far as their role in atrial fibrillation is concerned to prevent thrombosis, definitely so, as also for venous thromboembolism as well as pulmonary thromboembolism. They have an established role. But added to that, amongst all the NOACs today, the versatility of rivaroxaban as a NOAC amongst the three, though there are no head-to-head trials to compare between the three for us to say one is better or the other. But the versatility of rivaroxaban has got an approved role for CAD, that is chronic coronary artery syndromes, in a very 1/4 the dose what is available for the SPAF indication. By SPAF, I mean stroke prevention in atrial fibrillation. But to add further, now we always have the price to pay, as what we've seen all throughout, right from good old warfarin days to dual antiplatelets to even using, since I understand there is a exciting stent case also. Stents, when they first came in, like we used to use heparin and stuff like that, and then warfarin on top of that, until we came to know about dual antiplatelets. So this science of knowledge, so to say, of thrombosis and antithrombotic is going to continue to evolve. And rivaroxaban, as we all know, is a factor 10A inhibitor. But do you guys know that there is now a factor 11A, meaning trying to get more selective in the factor 11A is being worked on. A tongue twister of a molecule name there, acindixian or something like that. So that molecule is being tested in a phase 2 trial for AF again. So in AF also, we are concerned about balancing the bleeding on the one side and the thrombosis on the other side. So that is going to continue to evolve. Again, COVID coagulopathy is something that we really did not have the knowledge about it, and we claim to have knowledge or whatever, but we are using NOACs over there also. With that context having been said, we also let us know that my colleague moderator, Dr. Samir, as well as myself, we are not aware of what the cases, exciting cases, are going to be presented by our two speakers. And without much ado, let me hand over to Dr. Amay Chavan to show us what exciting thing he's going to do. And only thing is, I really understand that just briefly, I saw the title, something to do with stenting again. So let's see what role NOACs have to play here. Go ahead, Amay, Dr. Amay.
Good evening, sir. Sir, actually, I was not aware about the platform with regards to NOAC. So I was told that present any case that you have. So this is the case that I have chosen. So at the outset, I would like to point out that this case has got nothing to do with the NOACs. It's just a purely interventional case. It's a bailout case, which I would like to present.
Absolutely. And no worries. We would like to see that. And we could even go on to from here and try to see where coronary artery disease indication-wise NOACs would come at the end. Yeah, thank you so much, Amay. Go ahead.
So this is a story of a crumpled stent which I had faced in September 2021. So it is a story of a 57-year-old teacher diabetic who had chest pain for past half an hour and was referred from a tertiary care center. for a primary PCI. The patient was basically transferred in a cardiac ambulance from Wada to Thane. This was the ECG which was shared by the attending physician at Wada. So as you can see, there is ST elevation in the precordial leads. On his way to the hospital, he had 2 episodes of non-sustained VT. This was the ECG at presentation to the hospital. An echo was done which showed anterior hypokinesia with an EF of about 30%. There was ongoing chest pain, and hence it was decided to proceed with a primary PCI. This was his angiography findings done by the right radial root 6 French. Clearly a long lesion in the a tight lesion in the proximal LAD, and there was a long plaque following the proximal LAD extending right up to the mid LAD. RCA was fairly normal. There was also a lesion in the circumflex. The proximal circumflex showed a tight lesion extending into the OM about 90%. We discussed with the relatives, and the plan was to perform an angioplasty to the left anterior descending and circumflex. Right radial axis patient was loaded with 180 milligrams of ticagrelol, 7,000 units of heparin. Since patient was antiplatelet naive, we gave him 16 ml of tirofiban, 6 French EBU 3.5 via the right radial, Sean blue wire, predilation with a 2.515 NCR, 2.5 into 48 stent, and proximal optimization with a 3 into 15 NC. This was the plan, but it didn't go quite well. So I had predilated it with a 2.5 into 15 NC, following which I took a 2.5 into 48 stent. And if you can make out, I was not able to negotiate this point here, that I wanted to go about 2 to 3 millimeters more distally to cover the distal plaque. And in the bargain, this is what I landed up with. I could not negotiate the stent across the distal lesion. So I managed to get a buddy wire across the LAD in order to push the stent distally, but there was no avail. In a hurry, I decided to pull the stent back into the guiding catheter, and this is what I landed up with. Now, so the situation here is that we have got a situation of partial stent loss and a distorted or a crumpled stent in the proximal segment. So the options here were to pray, and pray. But the second option that I thought was to pull the stent balloon back, and the third option that I thought of was to pull the entire assembly back en masse. So this is the algorithm that we all very well know, that we have to inflate a small balloon at low pressure, try to retrieve the stent into the guiding catheter, and preferably a single marker long balloon. If we fail, then we try to deploy the stent, crush the stent, there it is, and deploy another stent. And lastly, if there is no avail, we could always send the patient for a surgery. Now, what I did here was I pulled the stent balloon back slightly into the guiding catheter. I made the guide catheter slightly coaxial here, and I had a buddy wire in place. So on the buddy wire, I inflated a 2.5 by 15 balloon at the mouth of the guiding catheter there. I gave a slight tug, and when I was sure that the entire assembly was moving en masse, I pulled the entire assembly out. Then I started searching for the stent, but I could not localize the stent anywhere. The stent had basically gotten trapped into the right radial axis. At this point of time, the thoughts were whether should I retrieve the stent or should I address the LAD first. And patient started complaining of chest pain. There was ST elevation. So I decided to address the LAD. I shifted my axis to a 6 French femoral. The same guiding was used. It took me good 5 to 10 minutes to cross the LAD because of the dissections in the proximal LAD. I did some aggressive predilatation with the same 2.515 balloon. This time, unfortunately, there were 2 CTO cases which were done in the lab that day. So the 48 millimeter stent was not available. So I had to go in for an Orsiro 2.540 distally and an Orsiro 3 into 18 proximally. Post dilatation was done with a 3 into 15 NC balloon. And since I had committed the patient that I would be doing the circumflex as well, so I addressed the circumflex with the same 2.5 into 15 balloon and a 330 Orsiro stent post dilated with the 3 into 15 NC balloon. And this was the final result. So I made quite a good number. I tried attempting to withdraw the stent into the right radial sheath for a good half an hour, but there was no avail. So I thought I would leave it there. So next day we got a Doppler done for the right upper limb, and the Doppler velocities were normal. So we decided to leave it as it is. So the risk factors for stent loss are severe vessel calcification, proximal tortuosity or angulation, equipment or operator points which are insufficient, guiding catheter or guide wire support, long stents, advancing or retrieving a stent through a previously placed one, incomplete lesion preparation, retraction of undeployed stent into the guiding catheter, and manually crimp stents. The take-home points from this case were that one should not undermine any coronary lesions. Call for help during a complication. Lesion preparation with use of plaque modifying agents is the key. Use of guide extension catheters for delivery of long stents in tortuous and calcified lesions. One should have snares on the shelf and have adequate knowledge of the same for equipment retrieval. Thank you, sir.
Can we come into this mode? Yeah, thank you. Well, that's quite an exciting thing. You play with fire, you're going to once in a while burn your fingers and you know how to get rid of it. Let me first invite comments from our moderator, Dr. Samir Pagad. How often have you had to retrieve stents, and what do you think about what Amay did, what Dr. Amay did? And we could stick to this, meaning how do we go about retrieving stents? Now, having said that, your last thing, what you said, manually crimp stents. So we were the fortunate ones that we grew in an era where we used to manually crimp stents, and stent losses was pretty much more common here. And then we used to even have the privilege to go to other labs and retrieve stents, so that is what it was. But what you said very important is that, see, it doesn't come telling you beforehand as to some complication could occur, and it has to occur, and you have to have the wherewithal to tackle it. Wherewithal, the operator wise, you have got to have experienced that before, and you should know all your hardware, especially the stent retrieval systems. The retrieval devices should be on shelf. Having said that, did you have one on shelf? Because if not, this experience would tell you that yes, it has to be on shelf. And many of private setups may not, many of small setups may not have these. So two things that you should have is coronary snares on tape in the lab, as also you should have, I would say, covered stents. Covered stents are also important when you are dealing with this. Now, I'll first invite comments from Samir about it. Samir, what do you think? You would have done anything differently? And in terms of taking in a long stent without having pre-dilated even the distal bed, invariably it's the chronic lesion that gives you the trouble, rather than the acute one is invariably a softer one and it heals well. So go ahead, Dr. Samir, what do you think?
Oh, thank you, sir, and thanks for this opportunity. I guess we all are on a nice platform. So going straight to the case, Amaya's case, I think you asked me whether I have faced this. Yes, all of us do go through these once in a while, but fortunately about just once I've had to face this. And I think whenever I have seen such cases being presented or seen such cases, the majority of the time, I think what you just said in the last, pre-dilatation or adequate bed preparation, that is more often the problem. When we try to shove in a stent without adequately pre-dilating or adequate bed preparation, that is where we try to usually put in some force. And then once it doesn't go, try to get it back. And that is where the stent gets stuck. The balloon just comes out. That is the most obvious or the most commonly known problem which cause these kind of things. Otherwise, stents today are very well crimped, and you usually don't face this if you're going to do it in a nice fashion. So it has become quite uncommon. But having said that, it is essential that we need to know how to go about it if we are faced in a situation, which we all do once in a while. So what Amaya did was, if I got it correctly, he pulled the balloon halfway out, the stent balloon halfway out, and then he took another 2.5 balloon at the edge of the catheter and then dilated it, and then he pulled the whole assembly out, assuming everything will be inside. Maybe what I would have done differently was, one thing is, try not to get that stent which has got degloved outside the wire. So if the wire is inside, try and preserve that wire as long as you can or as much as possible, because then you have no problem of losing a stent once you get it out of the coronary. Because having a stent inside the coronary, it is quite okay. You can try all your means. Since the patient didn't have ischemia, your various things. What I could have also tried, since he had another wire inside, which I assume was outside the stent struts, then you could have tried intertwining that and then, get the stent stuck in between the two wires and then pull all the assembly out. That would have been one way to get the thing out. The other option could have been using a smaller balloon, try to dilate that, and then dilated balloon, pull the whole assembly out. These are all theoretical ways. I'm sure he must have thought of it during that time, and whatever best he thought, he has done it. But this is the way I would have maybe approached it slightly differently and tried to keep the stent on the wire and not lose wire access.
See, invariably, that's very well points, all the points he has step by step said, our moderator. I would say that the coronary snare, when a stent is on a wire with or without a balloon, you are necessarily going to, like what it happened at the guiding catheter tip, the balloon came or stent was stuck, whatever. This stent, there is no way would have come out of your sheath, correct? So yes, unless you have got it securely over the wire. So you had a wire access and everything. So just before coming out there, the wire access, had it been retained, okay, when you're doing that, I don't know. It's always a panic situation in the cath lab. You want to finish. And again, the patient started complaining of chest pain. You want another access. You want more operators there and etc. But having said that, to get it out of that radial, your best chance was when that there was a wire there. And if you had a coronary snare, now just for the benefit of, I'm sure as dynamic interventionists, you all are aware of it, but at least the coronary snares, the good old microvena snare is what we call it, microvena, but now it's got different names and all. It's at a right angle to the wire, the snare part of it. And that there is a beak on that circle, okay? The beak diameter based on the whether it's a coronary snare or otherwise, the beak is something that will hold a guide wire within it, right? So you got to monorail it over the snaring catheter. A snaring catheter here would be like a micro catheter itself, right? And to get like a bigger than a micro catheter, but you should be able to grab the stent on the wire with the microvena around it and get it all together at an assembly when you want to get the stent out. It's perfect. What you did is about, you ensured by the side you got another guide wire. You ensured that everything will come as an assembly and wouldn't embolize up there. Once you're at the periphery, you're safe. Same thing when you do to the femorals. And to tell you very frankly, the PAMA shuts and all those manually crimped stents those days didn't have this kind of a radio opacity for you to figure out afterwards where down the leg it has disappeared also. With an angiogram, what would make out if it has caused something, some obstruction somewhere. So micro snares is absolutely a must on cath lab tables. And here it would have worked very well. So where, especially if a balloon wasn't there, you thankfully had some balloon there to get it. There's no way you could have got it with the balloon into the guide catheter or deflated it and got it in, which is a great thing you did, but not to lose it till the end, And if you have a chance to upsize the access through which you're going to come out, you should upsize the access to which you should come out. That is what I would just say. But the snare is something that is invariably not there. I don't know what did not prompt you to. Yet, if you were still on a wire, even at the radial end, you could have still got it out had you held it on the wire with a microvenous snare, is what I would say. But thankfully for the patient, at the end of it all, God is kind, and then that stent remaining in the an undeployed stent, remaining an unexpanded stent in an artery, is actually a milieu. Now, having said that, since we are on a NOAC business going on here and all, now, how much do you want to, what kind of an antiplatelet do you want to give, or do you want to add a, since rivaroxaban is what we are discussing also, do you want to add an anticoagulant empirically? It's not an indication, definitely, but do you want to add something to ensure that in the acute period, at least there is nothing happening to the stent which is stuck in the radial artery there?
Sir, I would not be prompted to add a NOAC here.
You wouldn't add a NOAC here, right? Okay. So therefore,
aspirin.
Just you give ticagrelol and aspirin, that's all you would manage with. Okay. What about anybody else wants to? So herein, it is off-label, but having said that, there have been trials in acute. It's not an approved indication for an acute coronary syndrome to use a triple antithrombotic therapy in sinus rhythm, though taking it from the other areas where patients are in AFib, you are allowed to use it, right? And we do use it, at least the minimum now we talk about in for patients on AFib who are undergoing a PCI, we give them for minimum a week. So the thing is that when we use a NOAC for coronary indication, in addition to that, with invariably the approved indication is with one more single antiplatelet on board and not a triple antithrombotic therapy. You go with a 2.5 milligram BID of rivaroxaban. Atlas trial is one trial where people did use it. Okay, the bleeding was unacceptably high, but the efficacy in terms of meaning thrombotic event prevention was definitely there. Atlas was a trial, Atlas ACS, and that's actually the basis for which this dose, as also another dose without the aspirin on board, got tested in the Compass trial. I'm talking about the vascular dose. We call it now the vascular dose of NOAC, and that is specific to rivaroxaban. So that is one thing. So I was only wondering if there is, for which again you want to take a bleeding risk history and you want to score the bleeding risk. If it's a low bleeding risk patient, then for a week or so, it is still fine to give it. Why not? Because your hemostasis locally is there. And just I'm thinking aloud. If it's a low bleeding risk, and because here the high thrombotic risk is not coming like Compass trial out of the coronary anatomy, or for that matter, arterial disease, ASCVD anatomy, or for that matter, comorbidities like CKD or diabetes, the polyvascular disease aspect is not there. But yes, within the coronary bed, there are two lesions there. And more importantly, there is a nidus for thrombus formation there in the form of an undeployed stent. So I was wondering, because if the bleeding risk is low, whether you would prefer a triple antithrombotic therapy at least for a week or so, so just to keep that artery paid. But it's of course all empiricism out here, not approved indication guidelines wise. Is there anything else that
I think
we have seen our second speaker, Rajiv? I don't know if you were there to the case presentation, but we were just talking about off-label use of a NOAC in this scenario where there's a undeployed stent in a radial artery and there is a double vessel PCI in a primary PCI scenario. Whether you would have been in any ways using a off-label indication of rivaroxaban 2.5 on top of, but of course ticagrelol is already on board. So having said that, even in an ACS scenario, especially the Gemini ACS trial also, ticagrelol on board, also 2.5 rivaroxaban has been there used along with aspirin. Yes. Bleeding risk is of course high. Yeah.
I probably would have continued only dual antiplatelets.
Okay. So that radial, any which case, radials are known to disappear unpredictably, asymptomatically, they may disappear. So
6% radial pulse loss after.
Oh, no. We just did there is a recent review. I think it was doing the rounds also in our WhatsApp group. But that review, we did do it in our journal club at my university hospital. And out there, the incidence varies from 2 to 34%, depending upon what you are defining as a loss of radial, ultrasound guided, or meaning you want to do a local ultrasound and figure it out versus asymptomatic, of course. I think 2 to 34%, that wide variability. In experienced hands, of course, it will be, that's a good average that you're talking about.
My feeling in this case, sooner or later, his radial is going to occlude for sure. When we have a 48 millimeter crumpled metal mass there, it is going to occlude. So if we are really concerned, maybe I would have even thought of a small surgery and get it out.
Exactly. I was wondering that,
that if his, but at the other hand, again, then anyways, we lose radials in 30% cases, as you say. So might as well one more. So that's the other way arguing out.
Say it was stuck in an other important area where you do not want to access, then definitely empirical use of an anticoagulant in addition, if bleeding risk is negligible, then one could go ahead and do that. Okay, great case. And it requires guts to present complications and then coming out of it. I would love to also see complications in this scenario where you are not successful necessarily, and yet one could discuss those. No? As we used to say that successes have many fathers, complications are all orphans, right?
One small thing I noticed in his presentation before we end this case, Amay, you did mention ticagrelor 90 mg 2 tablets loading as well as tirofiban. I mean, how often do we all use tirofiban along with ticagrelor? Don't you think there are 2 potent drugs already and then an aspirin, 3 drugs? Is that a common practice we all follow? At least I have stopped using GP2.
No. Tirofiban and all is more for the cardiologist's mental state, so to say, thrombotic milieu. So we have used. But I don't think it's an approved indication also, right? Upfront to give.
Yeah, because you have a very
upstream to give tirofiban is not an indication also, right?
It was a small point, I think, which...
If at all, cangrelor instead, maybe a thing which is a short half-life, you stop it and it's gone, that kind of thing. Oh, I didn't hear that part about tirofiban. Okay. So that's not like an indicated, again, not an approved indication. Well, thank you so much, Amay. That was an excellent presentation and a great retrieval. It requires a lot of experience and, of course, the presence of mind to do all what you did, and you came out unscathed, which is a great thing. Congratulations.
Thank you, sir.
Congratulations on that. Yeah, so let's have the next case now. Yeah.
So, Dr. Raju, would you share the screen?
Yeah, I'll start sharing my screen. Is my presentation visible?
Yeah.
Yes, very much.
Yeah. Good evening, and my deepest regards to my teacher and mentor Kirkar sir, and warm regards to my senior colleague Samir Pagat sir. Also a hi to Amaya, and I'll be discussing a case of the classical case which was in the COMPASS trial, and we have adopted this approach fairly well in our clinical practice now. So I'll be discussing on that. So here I have a 61-year male who is complaining of class 2 angina, stable angina for 1 year. So it has been there for 1 year and also has a history of claudication. He is a case of diabetes, hypertension. So risk factors for CAD and PAD are diabetes and hypertension. About the ischemic heart disease, the details are that he's undergone a PCI to LAD 12 years back. There was ISR, patient underwent a CABG. The CABG, the radial graft to the right coronary occluded, and a stenting for RC was done 3 years back. So it's a revascularized patient and has diffuse atherosclerosis of the palatal lower limbs, which are claudication producing. So it's a significant disease. EKG is LV hypertrophy, echo mild dysfunction, inferobasal hypokinesia. Doppler studies are a diffuse disease, infrapopliteal. Coronary angiogram shows patent grafts and totally occluded LAD and RC. Native coronaries are occluded. Circumflex is flowing well. Mild CAD is there. So basically my diagnosis is it's a patient of coronary artery disease with patent grafts. Patient has class 2 angina, which could be microvascular, which could be due to distal perfusion issues with even patent grafts. So distal diffuse disease with patent grafts can produce class 2 angina. Also, our patient has infrapopliteal peripheral artery disease and diffuse calcification of the lower limb arteries. Treatment regimen: patient is on aspirin 75, rivaroxaban vascular dose 2.5 BD, rosuvastatin 20, keeping his LDL below 40, metoprolol 50 OD. This patient did not have a pre-popliteal disease, so metoprolol was continued, and beta blockers and PAD were taken into consideration, but more often than not, I continue beta blockers in PAD patients as well. Ramipril was there. There was a mild LV dysfunction, but ramipril was going on. Ranolazine 500 BD as an anti-anginal was continued. For diabetes, sitagliptin and metformin was controlling the sugars fairly well. So now about the discussion about my case, there are a few slides with kind permission from sir. I will go ahead. Patients with coronary artery disease remain at a high risk for recurrent ischemic event. So if a patient has only risk factors, no event yet, the recurrence is 9.1% at 4 years for death, MI, or a stroke in the REACH registry. If the patient has stable disease, the recurrence increases to 12.2. Prior ischemic event less than 1 year, the recurrence risk is 21%, and more than 1 year it is 17.2. So we see that the recurrent event risk increases as the disease progresses. So from risk factors to an established disease recently, the recurrence risk is very, very high. What are the current medical options available? Lifestyle always remains the baseline pillar. Healthy lifestyle changes are extremely important. Smoking cessation, good diet, physical activity, managing weight, psychological stress, sleep, etc. Then we go to lipid lowering. We have statins, ezetimibe, PCSK9 inhibitors. We target as low LDL as possible. In fact, Lipid Association of India guidelines says LDL should be less than 30 in such patients with polyvascular disease. We do aggressive blood pressure management. We keep the targets as less than 130 by 80 in all. Particularly in these patients, we make sure that the BP is controlled well. Glycemic control, we focus on cardio-safe anti-diabetic medications. So the sulfonylureas go down in the arm, SGLT2 and GLP-1 agonists. Although GLP-1 is injectable, we don't really use it well in clinical practice. So metformin, SGLT2 inhibitors are the first choice. DPP-4 inhibitors are not very efficacious, but they're cardio-neutral. So we use sitagliptin and we use linagliptin to our benefit. After that, what we do is a basal insulin regimen. Basal insulin, if non-affordable, we go to sulfonylureas, and thiazolidinodiazepines, we preserve it for the end because of its heart failure potential. And antithrombotic therapy, what we have been doing is aspirin monotherapy for most of our patients with chronic coronary syndrome. Then we went on to dual antiplatelet therapy with aspirin clopidogrel. Then there was data for dual antiplatelet therapy with aspirin ticagrelor. And now what we do is a dual pathway inhibition of aspirin and vascular dose of rivaroxaban. Is there any scope for improving? Yes, what we see is the coagulation cascade. So extrinsic pathway, intrinsic pathway, both activate factor 10 to factor 10A. 10A activates prothrombin to thrombin. Thrombin generates fibrinogen to fibrin, and then there is a firm clot formation. Rivaroxaban, apixaban work at factor 10A level. Dabigatran works at factor 2A level. So what are the antithrombotic regimen? So stable patients on aspirin monotherapy, if they have a history of multivessel disease or an MI between 1 to 20 years, and if there is additional risk factor, we consider oral anticoagulation if there is an indication. For example, atrial fibrillation is there, or a patient has another indication for like a deep vein thrombosis, any other indication for oral anticoagulation. Or if there is a high risk of life-threatening bleeding, then if there is a high risk of bleeding, we avoid using vascular dose of rivaroxaban. If there is not a high risk, a very high risk of bleeding, and there is an indication for anticoagulation, we use aspirin plus rivaroxaban vascular. So we add rivaroxaban 2.5 BD to these patients. who have an additional risk factor for ischemia, additional need for anticoagulation, and very low bleeding risk. If the bleeding risk is high, we continue with aspirin, and instead of rivaroxaban, we switch the patient to ticagrelor 60 milligram BD dose on the basis of the Themis trial. This is for a stable patient. If the patient is come with ACS, we do an angio. If a CABG is done, 12 months of DAPT, then we again go to the same algorithm. If PCI is done, if it's an extensive disease in a diabetic patient, as sir was discussing with Dr. Ameya's case, if it's an extensive CAD with diabetes, risk factor, severe multivessel disease, and the patient is intolerant to ticagrelor, then we give aspirin plus clopidogrel for 12 months, reassess the risk factors, and give a vascular dose of rivaroxaban. So this is what is in the guidelines now. So in 2019 guidelines, it is a class 2A recommendation to add aspirin and a second antithrombotic therapy in a patient who have a high risk of recurrent ischemia without a high bleeding risk. If it's a moderate risk of recurrent ischemia, it's a class 2B indication. High ischemic risk, which are the patients with high ischemic risk? Diffuse disease with diabetes, recurrent MI, PAD, CKD with GFR of 15 to 60. What is moderate ischemic residual risk? Multivessel disease, diabetes, recurrent MI, PAD, heart failure, CKD. So in a high ischemic risk, it is this plus one of them. Here it is either of them. Even if it is one, it is a moderate ischemic risk. In a moderate ischemic risk, using a second antithrombotic is a class 2B indication. If it's a high residual ischemia risk, it's a class 2A recommendation. So dual pathway inhibition, how did it come into practice? What we realized is in the initial phase after an acute event, platelet activation plays a very strong role. And subsequently, platelet activation no longer remains the key problem. The key problem remains prolonged thrombin generation. So on the basis of this hypothesis, in the COMPASS trial, patient was randomized to aspirin and rivaroxaban. So what are the trials that are available? So for antithrombotic therapy after an event, Capri was on clopidogrel. The overall net benefit of bleeding versus a recurrent event was not very favorable. Then came Charisma for clopidogrel plus aspirin. Although these are not head-to-head comparisons, so I'll highlight that they are not trials done with direct comparison to each other. They are trials in their own. So Charisma data had a fairly high gusto moderate bleeding. So overall net benefit was not MACE reduction was by 7%. Pegasus compared to a bleeding risk increase of 60% over monotherapy. Pegasus was on ticagrelor and aspirin. MACE rate reduced by 15%. Overall MACE rate reduced by 15%, and TIMI major bleeding increased by 160% compared to monotherapy. Pegasus 60 ticagrelor plus aspirin data reduced MACE by 16%, and the TIMI major bleeding was increased by 132% compared to monotherapy. So here is where 60 ticagrelor came into picture, and then there is COMPASS. COMPASS is on vascular dose of rivaroxaban plus aspirin, MACE reduced by 24%, and modified ISTH bleeding was increased by 70%. Overall net clinical benefit was in favor of combination of aspirin and rivaroxaban. So COMPASS is the only trial which showed a significant reduction in all-cause mortality as well. CV death was reduced by 22%, statistically significant. What is the patient profile of COMPASS? So patient should either have a chronic coronary artery disease, stable coronary artery disease, a peripheral artery disease, or both of them. So our patient had both CAD and PAD. So we used a rivaroxaban vascular dose to his benefit. Now, what is the criteria for a CAD patient? Past MI within 20 years, multivessel disease on angio, multivessel PCI, multivessel CABG, and patient must have either age more than 65 or less than 65 plus atherosclerosis in two vascular, polyvascular atherosclerosis, or two risk factors. So this was the criteria subset for COMPASS trial CAD patient. PAD patient was a patient with prior revascularization, lower limb burden, or a foot amputation, or a history of intermittent claudication with ankle brachial pressure index of less than 0.9, significant peripheral stenosis on angio or a Doppler, previous carotid revascularization, or a CAD with a low ankle brachial index of less than 0.9. So patient should either have CAD or patient should have PAD or patient should have both. This was the COMPASS trial subset. 27,000 patients, run-in aspirin was there. Rivaroxaban plus aspirin, rivaroxaban 5-BD or aspirin monotherapy. Patients were followed up for 1.9 years. And it showed a statistically significant reduction in MACE in patients with stable coronary artery disease. Whether to use the term stable coronary artery disease remains a controversy, but the subset of patients that I described in the previous slide is what was the patient of CAD in the COMPASS trial. So main outcomes, we see the curve reducing and diverging in the favor of rivaroxaban and aspirin. Net clinical benefit was reduction in MACE by 24. Bleeding risk versus MACE minus if we do the net clinical benefit was by 20%. Mortality reduction by a whooping 18%. Rivaroxaban alone 5-BD did not have a mortality benefit. So this was on the basis of different cohort. In PAD cohort, overall COMPASS trial also, the benefit was skewed in favor of rivaroxaban plus aspirin dual pathway inhibition. So clinical implications of COMPASS, we switch from DAPT to dual pathway inhibition. We should look for an opportunity to do that in a patient with stable coronary artery disease and high residual ischemic risk and a low bleeding risk. So we have to search a patient with stable disease, high residual ischemia, polyvascular disease, and a low bleeding risk. So these are the ideal patients who we can enroll for a dual pathway inhibition, and we can utilize the benefit of the molecule's vascular dose. So NICE guidelines also recommend that rivaroxaban plus aspirin is recommended as an option for preventing antithrombotic events in patients with CAD or PAD who are at a high risk of ischemic events and low risk of bleeding events. Thank you. I will stop sharing my screen, and I would love to learn from Kerkar sir and Samir Pagar sir.
Well, thank you, Rajiv. That was a fairly lucid presentation, and you covered everything about what we call today a dual pathway inhibition and how a dual pathway inhibition might have similar or slightly lower bleeding risk than dual antiplatelet, especially with the modern second antiplatelet agents that we give. Okay. As also importantly that it shows MACE outcomes coming down, as also a benefit towards mortality, especially cardiovascular mortality as well as total cause mortality. However, statistically that mortality definition, meaning how much you should talk about, is a different matter altogether. But yes, that's a very exciting concept. And as a NOAC, being a part of chronic stable coronary artery disease, stable, or rather you should call them chronic coronary syndromes now. Why they are not stable? You did raise that question about it's not right to call them stable. Your first slide itself, that Deepak Bhatt slide that you showed, that over the next 4 years, there's, for your kind of a patient, there's a 21% risk of getting recurrent events, which means we are talking about an annual event rate of almost 4 to 5% per year annual event rate. And when we just prescribe a single antiplatelet, for that matter, dual antiplatelet, we are not really yet reducing the residual disc that this patient has. He so-called comes to a follow-up OPD, is complaining of some angina, you just modulate therapies and you think we are doing fine. Until one fine day, he gets an ACS, gets worsened, loses LV function and things. So we got to work on them. And not only that, there is that bed, the coronary bed, but your patient has got the classical COMPASS enrichment criteria, as we call. That's fine. Now, just to digress a little bit, as far as anti-diabetic therapy is concerned, and that what you said, lifestyle intervention and metformin. But just today, was it, or yesterday, I briefly read somewhere that the DPP, the diabetic prevention study or whatever they call it, right? 18-year follow-up of it and lifestyle intervention and metformin have got nothing to do with MACE outcomes, which again means that your patient is not on the newer antiplatelet therapy, anti-diabetic therapies, especially SGLT2 inhibitors, which have now gotten approved, and we should always, unless affordability, now that they are off patent also, so they should be thought of as first-line drugs for pre-diabetics as well as morely the diabetics, though this study was about pre-diabetics and their MACE events, I think, both diabetes as well as pre-diabetic MACE events. So that is important as far as anti-diabetic therapy is concerned. Again, you also told us that the guideline indication for a dual pathway inhibition class 2A for the very high thrombotic risk and class 2B. But underlining all that is that, which I feel is extremely important, is that patients at low bleeding risk. You know, that is extremely important. So how do you in practice really, how much do we go at the bleeding risk? Because the similar criteria which are there for thrombotic risk would be there, especially patient characteristics. Those patients will also be at say you have CKD. CKD itself puts them at high bleeding risk, isn't it? The elderly age puts them at high bleeding risk. So how do you go about it? Do you mentally do it? I was asking one of these international, so many a times people came along, especially when the 2.5 BID dose became off patent, right from Keith Fox to everybody, to Deepak Bhatt to everybody, we were asking such questions. So is it a mental thing, or do you do some bleeding risk, scoring risk, like you do for CHADS2-VASC when you are deciding about a preventive therapy? After all, dual pathway inhibition is a preventive therapy. You have to proactively go. So do you guys do something? May I ask Dr. Samir Pankaj as to how do you go about deciding on a bleeding risk? And that's some important message that we need to give. First, look at the bleeding risk for somebody who's especially just on a single antiplatelet and you want to add a second one. This patient also, he deserves to be on a dual antiplatelet, definitely so. But just if so, chronic coronary artery disease patient who's on a single antiplatelet and has got all these risk factors, are you going to think about a second DPI strategy, and how do you go about it? Doctor?
I would agree, sir. It is kind of a gray zone where, let me put it across, like as you said, it has similar characteristics, the bleeding risk as well as the thrombotic risk scoring, if we have to do. Now, if there is moderate bleeding risk and a moderate thrombotic risk, then where are we? What do we do? Like, do we err on this part or do we err on this side? And
so therein again, when it's a moderate thrombotic risk, he showed us the guidelines, and it's a class 2B indication.
Yes,
it's extremely high thrombotic risk and absolutely low bleeding risk. That's where a class 2A indication.
Ideal situation that would be. But what if we have a high bleeding risk and a high thrombotic risk also? Then where are we, and how do we go about practically? That would be where the clinical judgment would come in handy, I guess. And that's a very difficult situation to be in, unless, because you can err on either side. One is act of omission and an act of commission, if I can put it that way. You're trying to put in a drug and that can cause bleeding, and that you feel horrible at the end of the day.
Right.
The service, again, thrombotic is always there, that you're not done enough to prevent a problem as such.
So I think the one way to get over it is to explain the family, explain the people also as to what we are doing, and to be proactive. And an error of commission is what we should be looking into, especially for people with high thrombotic risk, like previous lacunar stroke, this, if at all that's going to kill you earlier, and bleeding, if you are okay on that front, then one would think about. But of course, with the high bleeding risk, we are fine not getting onto it. So that's one thing. There is a good, the ARC definition, ARC people know this. The bleeding risk by the ARC criteria, they have got a nice pictorial, in that particular article, which actually we picked it up, and it is good to keep it in your outpatient with this thing or otherwise, and that gives you a mental checklist. Again, a history of bleeding is the strongest predictor for that. So to check on that is one thing. Otherwise, this dual pathway inhibition, especially in the elderly people, can also bring about, you may get this thing coming up, you may unmask malignancies, GI tract malignancies. So you can unmask in the very elderly. So having said that, we experience disease a decade earlier, right? ASCVD in Indians is a decade earlier. And we suspected that Indians may not bleed as much. As it is, we see rampant dual antiplatelet prescriptions going lifelong, right? Meaning it's there and people, that's again, we know that they haven't bled in the past and therefore it does go on. They don't necessarily get converted to single antiplatelet, especially with clopidogrel, since we have combinations available. So that is where we got to be careful and we got to look into it, is what I was just trying to say.
From a practical point of view, if I may ask you a question, since now it's been at least a couple of years since we have started using this rivaroxaban vascular dose, have you experienced patients who come back with severe bleeds or significant bleeds?
No, I haven't really. I'm telling you, I haven't really come across this. Yes, sometimes the troublesome bleeds, little ecchymosis here and there, or during blood collection for their bloods, they bleed more, is there. So I'm happy to tell them that this is because of this that you're bleeding more, which means the drug is acting. That's what. But I haven't experienced an IC bleed yet. That's the most scary thing, right? But I make it a point. I'm just telling you that because we are proactively doing, and we actually analyze the COMPASS data as a statistical exercise, looking at the NNTs and the NNH on DPI within the COMPASS trial. If you know, there were patients less than 65 years of age also. Okay, but who had to have multiple comorbidities and multiple risks to get included. They had to be high risk to get included in the trial. They're pretty much a high risk population. And when we separated out the younger people with less than age 65 and more than age 65, the net clinical benefit, meaning net benefit, the NNH and NNTs, were so much towards, favoring the thrombotic efficacy of this regimen, that we suspected, therefore, in an Indian scenario where our patients are typically younger patients, so bleeding may not be expected in a way. The only way is when cardiologists come together and pull into some kind of a registry for us to understand whether the DPI strategy is bleeding. And maybe that's where MQR pharmas like that, which they should come up and help us collect some registry data, that way, to understand, which you asked me, but I have not experienced a bleed on this kind of a strategy. Yes, but I do monitor hemoglobins also, and one elderly patient, she's like with a pacemaker, she's got a DV-CAD, which she doesn't want to get operated upon, diabetic, and the works, and LV dysfunction, and she's on this dual antiplatelet strategy. And suddenly she started getting some anemia, which was not related to it. It was mainly nutritional. Her husband had expired. She was hardly eating, and iron deficiencies was the reason. But you should look for anemia also in these people, is what I was trying to say. So with that, I think we have pretty much covered anything. Is there anything Dr. Amay might like to add on the dual antiplatelet strategy? Sorry, I mean the DPI strategy.
Yeah.
Would you like to add something?
So I think we are all on the same page with regards to that. So in CCS, single antiplatelet with vascular dose of rivaroxaban is the way to go.
Yeah, just that his is a very typical case for a COMPASS strategy. How early would you in your practice start? Meaning it's the time when, as interventional cardiologists, we come across is when a year has elapsed, right? And then the dual antiplatelet, you might want to stop. So what is your practice? Really, post an ACS event, you would switch from a dual antiplatelet at the end of 1 year itself, or would you wait longer on a dual antiplatelet and then switch to a DPI? Or how impressed are you with COMPASS vis-a-vis the other trials of dual antiplatelet?
But I basically
with the potent antiplatelets. Yeah, go ahead.
So I basically at the end of 1 year, I make it 60 milligram ticagrelol, and I preferably continue it for another 3 years. And then probably we can switch to a rivaroxaban 2.5 with an aspirin of 75.
So you go typically on your gut feeling, or you go by some data for saying that I would go?
No, this is purely for ACS patients, sir.
ACS patients, okay. Yeah, so ACS patients, because we would like to look at the thrombotic risk, is mainly not looking at the risk elsewhere. We would like to look at the coronary event rates, right? And the coronary event rates, like how much of an aggressive intervention you've done. because the same criteria come for dual antiplatelet. What Dr. Rajiv showed us, guideline criteria, that comes for dual antiplatelet as well. But I would agree with you, if your thrombotic risk is high and if it's not a polyvascular, even if he is a polyvascular disease patient, by polyvascular I mean in multiple beds, then my inclination will be towards getting earlier onto this.
I think with an ACS or a procedure, if he has undergone, the first year he should be on dual antiplatelet. And for sure. And then you might want to go to the COMPASS trial, or a COMPASS dose, if you can call it, where you can use a rivaroxaban vascular dose and aspirin if you want. That can be the standard guidelines, if you have to call it.
Exactly. But we are justified because we like to look at the coronaries. We like to look at our stents, which are multiple out there. So going by that, the DAPT study itself, right, the original DAPT study itself, there was a 30-month data on dual antiplatelet also, that atherosclerosis, not necessarily the stented lesion, we are by and large safe, but atherosclerosis elsewhere, that's where you're going to get the event coming up. So maybe we should go on. Maybe we could go longer with dual antiplatelet and then switch. But switching to DPI with all these enrichment criteria, if there, especially there is a mild CKD or LV dysfunction on top of that, and if you have had a prior stroke, because in the MRI sub-study also, they try to stay away from strokes in the terms of inclusion criteria for, correct me if I'm wrong, except for unless you had a non-lacunar previous stroke or whatever for increasing the risk. But they did not necessarily pick on stroke patients, right? But in the MRI sub-study of COMPASS, as high as 14%, or I think it's about maybe 30%, I don't remember the statistics. But there is a large chunk of asymptomatic MRI-wise, they had strokes, they had thrombosis there, somewhere, some artery, some areas, there's some old infarcts there in the brain. So it makes sense, especially the elderly population, it makes sense to be on a DPI rather than this if the bleeding risk is low. So with that, if anybody else wants to add something, or otherwise we'll hand it over back to Lakshman Patel. Very insightful cases, very nice cases to have discussed.
I want your opinion on two short questions. First is, in dual pathway inhibition, do you think clopidogrel plus vascular dose of rivaroxaban can work?
That's a great question. Actually, if you ask me, why not? There is no pure statistical date since the last trial is with aspirin, but taking it from the Gemini ACS trial also, therein combining this with dropping an aspirin, or even dropping an aspirin from our AFib scenario in Augustus trial and all these areas. We are happy. We know that aspirin is the usual suspect for this. But this is going to be, again, your clinical judgment, and I would be happy doing it. But when I do that, or for that matter, are you as a single antiplatelet confidently giving patients clopidogrel and not aspirin?
Yes.
Are you, for a patient, you're doing it, right? But this hype that started, good old days when clopidogrel came, just like how ticagrelor is so new to the country. Likewise, when clopidogrel came, there was so much thing about the genetic variability that there could be, and the hyper responders and the hypo responders or the zero responders. And today this gene study, at least, meaning even in our university hospital, it's available, and across it is available. For somebody who has got a high ischemic risk, I might want to, and you're going to give it for lifelong. So why not check on his genetic? This is again off-label. I'm not saying this is one of the clinical ways of going about it,
Sure.
So whether you would want to get onto clopidogrel lifelong instead of aspirin, got a clear GI evidence or something like that, or intolerance, not necessarily intolerance, but with acidity issues and all that, you might want to go to clopidogrel, but then you might want to check on this because it is in literature described, right?
Sure.
Yeah.
I would be very skeptical, to be honest. We all at least believe that clopidogrel would be slightly more potent than aspirin, and that's why we would prefer to use it as a single antiplatelet after 1 year rather than aspirin. In the same breath, if we are going to use it with rivaroxaban and clopidogrel, maybe I would be a little worried about the bleeding risk more than...
Not really, because if at all, it might be a little less is what it is, drawing analogy for this.
Yeah.
And it is not any higher with antiplatelet, with dropping aspirin from the Gemini ACS. I think that was a trial where you had this dose tested out, and with ticagrelor when used also, it was not causing any higher bleeds. The safety point of view, we are okay. But in terms of whether it works with this, in terms of that clopidogrel is working, that's important, right?
Okay.
I was talking about in a single antiplatelet scenario. If you're doing it in a single antiplatelet scenario, I think you're fine to do it with this. But this is again off-label. You don't want to do it.
We can always argue there's no data as such.
There's no data. But yes, there is safety data available from the Gemini SCS trial.
Sure.
Okay.
Thank you, sir.
Great. So let's move on. Lakshman, Dr. Lakshman, all over to you.
Yeah, thank you, sir. I think it was really fascinating discussion, and presenters have presented great cases. I'm sure the delegates must have made note of it, and they must have got a lot of insights from today's discussion. And thank you very much, Kerkar sir, for making this program, keeping this program live and engaging. And we would love to continue having such programs, which would be really appreciated by all the participants. So once again, let me thank all the doctors, all the delegates. Then I also thank Dr. Pagat sir, Dr. Amay sir, and Dr. Raju sir for giving their valuable time for this program and making this program worth to attend. Thank you, Kerkar sir, once again. And
thank you so much.
Thank you.
Thank you, dear. Thank you, Amaya, Rajiv, and Samir. Yeah.
Thank you, sir.
Excellent
Good night.
discussion. Thank you so much.
good night.
Bye.